What's up, guys? This is going to be a quick video on colonic polyps and looking at how some of them can turn neoplastic and some of them are actually benign and don't have the threat to become neoplastic. So let's jump right into this. We're going to start with just the basic main types of polyps and then go through some of the details and various subtypes within each of these. So let's start with the first one. The first one is a hyperplastic polyp. So this polyp, to begin with, is not it can't normally turn into a cancer unless certain situations are present with the polyp. And I'm going to give you the situations that any polyp can become cancerous over here on the side. So the first thing you're going to look for is if it's really large. If the polyp is extremely large, it will increase the chance that it has the possibility to become cancerous or neoplastic. The second thing is it has to be sessile, or doesn't have to be, but it will increase the chance of it being cancerous. So if you're dealing with a polyp that's normally non-cancerous, sessile just means that if you're looking at the mucosal surface, say we're looking here, you have polyps that can either be pedunculated, that means that they have this like little stalk thing that connects them to the side, or you can have a polyp that instead of having a stalk, it's kind of firmly attached all the way across from each of its borders, whereas here it gets wider as it goes into the actual foundation of the polyp. So this is called a sessile polyp, and this one's called a pedunculated polyp. So if you have sessile polyps, then you know that that has an increased possibility to become neoplastic. Okay, and then after that, there are various types of polyps. There's certain ones that are that have a higher chance to become cancerous just by themselves. And that particular type is called, if it has a villus histology. So, villus sounds like villi. And remember, when we're talking about villi, we're talking about that kind of structure, like in the small intestine, mainly in the duodenum, where you have this kind of thing going on. These are villi, and they help with absorption in the small intestine. And so, as far as if you have a villus histology, that just means that it's going to have the same look as the villi that are in the small intestine for absorptive purposes, but it'll have that same look. And you'll see one of the things that it can do later, because it has a villus histology. There's a type of polyp within the Adenomatous polyp category that's a villus adenomatous polyp, and that is the one that is the highest chance to become malignant of any polyp, but we'll get into that later. So that's just to kind of start off. So normally hyperplastic polyps, we're back talking about here. Normally hyperplastic polyps are not malignant, or don't have a chance to become malignant. But if they're sessile, then they can have a very slight chance to become malignant. So all hyperplastic polyps, or we're talking more or less if they have that sessile design, remember that they can become more malignant. But in hyperplastic polyps, first of all, they mainly are in adults. They have a sawtooth appearance, and I'll show you what that means. And also, I haven't seen a lot of resources cover this, but it's kind of important to know for recognition on histological slides, is that this has a star. These have like you could say star-like crypts, and I'll show you what I mean. So we're going to get into the picture of a hyperplastic polyp, and I'll show you some of these features. So to begin, this is just showing you a hyperplastic polyp, and if we were to zoom in, let me see if I can zoom in to kind of show you, zoom in. Okay, so I want to zoom in here. If you look closer at this hyperplastic polyp, you can see, if I go back to my pen feature, I don't know why it won't let me do both at the same time, but anyways, we can still see it from this. You see this pattern of going up, down, up, down, up, down, up, down, up, down. As it goes through, it's doing this kind of pattern. That's what's called a sawtooth pattern, okay? Sawtooth pattern. And that is fairly diagnostic for a hyperplastic polyp. Okay, and then the next feature I said is that it will have star-like crypts. So look at the crypts. Do you see this kind of look? Like if you look within the crypt itself, you see this kind of thing going like this. That they're saying that looks like a star. You could say that a star would kind of be like this. Then they have these various, especially in that one right there, this one. These are all star-like crypts, and that's also That's also a feature for a hyperplastic polyps. And then again, it's primarily in adults. Okay, but for the most part, this doesn't have malignant potential. The only way this would have malignant potential is if it would be a sessile. And let me remind you one more time, sessile is when it's attached firmly to the mucosal surface. And then you have the pedunculated ones, and those are the ones that are less malignant in their type. So if this was a pedunculated hyperplastic polyp, it would not have any sort of malignant potential. Okay, so we're going to move into our next thing. We're going to look at Hamartomatous polyps. Now, the important thing about Hamartomatous, first of all, you have to know what a hematoma is, or a Hamartomatous feature. And that just means that you have the features of the normal, let's say, tissue there. So it's going to have the, so in other words, if we're in the GI tract, right, and we're in the duodenum, whatever, like, I'm not going to go into the details of what the duodenum is for the histology, what it has, but if you had a Hamartomatous polyp there in the duodenum, that would just mean that you have the tissue, it is made up of the tissue that is from the duodenum. So it's not like you're going to have, stomach tissue within the intestine. You're going to have intestinal tissue that makes up this, but the tissue is going to be having a lot of cartilage and fibrin type products in it. Okay, so that's just the general kind of features of what a hematoma is. So now if we get into the Hamartomatous polyp, there's two primarily syndromes. There's types and syndromes within this. So you'll see what's called a juvenile polyp in something called juvenile polyposis. So that tells you juvenile stands, that means it's a kid, so this is usually in children less than 5 years old. And juvenile polyps have a certain feature. Let me see if I have a picture of it. Yeah, here it is. So the picture in juvenile polyps, this gives it away. If you know they're talking about a polyp in the description, say in the question stem, you see these mastic cystic glands, massive cyst-like glands. That gives it away that this is a juvenile polyp. Okay, so that's one of the histological signs. And in juvenile polyposis, the patient, of course, is a young child and will have, let's say, 10 to 15 or 10 to 20 polyps, and it can be in varying tissues in their body, and they'll have this massive cyst-like gland feature that you can recognize them as juvenile polyps. Also in this, you can see that they could have a polyp in the colon, in the distal colon, and it can prolapse. So that just means they're at their, if you look at the child's anus, you could see that it could be coming out and prolapsing outwards. You can actually see the polyp if it were to be kind of there in the rectum area. Okay, so that is some of the features. So that's the first one of the Hamartomatous polyps, is the juvenile polyps within within this juvenile polyposis. So the second one is going to be, now I'm sorry if I misspell this. This is kind of a complicated word. Poites-Jager's, I think that's how it's pronounced. Maybe there's this EU. So Poites-Jager's syndrome. And this is polyps that can appear anywhere, but there's a ton of them usually in the jejunum. And then also in Poites-Jager's, they have a very diagnostic feature. You'll see hyperpigmented mucosa on the lips. And I'm going to show you a picture of that. So when you, let me show you here. Let me clear all the stuff I wrote. So in this picture here, you see this. Now, do not get confused with this feature versus the feature of hereditary telangiectasia. Remember, in hereditary telangiectasia, they could show you the inside of their lip, just like in this patient. But in hereditary telangiectasia, you're dealing with issues of blood capillary problems, and so these in hereditary telangiectasia, it would be more red. But in this situation, you see how these are all very dark brown to even black in some patients. So that's kind of a diagnostic feature. If a patient is dealing with polyps, especially a ton of them in the jejunum, and they have this feature, this hyperpigmented spots or lesions on their lip, then you need to be thinking of Poites-Jager, which is the second one of the Hamartomatous polyps. But overall, Hamartomatous polyps don't have the potential for the polyps themselves to become malignant, although you can see some increased incidences of malignancy in other organs of the body, depending on the syndrome and how it affects other organs. Okay, so we're going to move into the next section. This is just inflammatory polyp. I don't have a picture for this because this is actually not a real polyp. It's what's called a pseudo polyp. And these just form, you just need to know that these form in inflammatory bowel diseases. So what are the two inflammatory bowel diseases? That's going to be Crohn's disease and ulcerative colitis. Okay, so if you have really severe chronic issues of Crohn's disease and ulcerative colitis, that constant irritation and fibrosis can form these pseudopolyps or they can be called inflammatory polyps, and they're not really polyps, they just arise because of these inflammatory bowel diseases, and they don't have the potential to become malignant. Okay? The last section, and I would say what is the most high yield, is the Adenomatous polyps, and there's three primary subtypes within this one. There is tubular, there's villous, and then there's one that's mixed between the two, and it's tubulovillous. Tubulovillous is fairly low yield because there's not much to say about it. The more primary thing is going to be on both of these. Okay, so let's get into some of this, how each of these look. Let me clear the writing. The first one I said is the number one is tubular, and that's what's shown here. Tubular. So tubular adenomatous polyp. Adenomatous, they're called adenomatous because an adenoma is like a you could say a mass, a cancer, right? A glandular cancer. And so these polyps all have some malignancy potential, and some of them more than other. Some malignancy potential. These are the ones out of all of them that can become malignant. Okay, so the first one is tubular adenomatous polyp. Well, it tells you right there. Tubular kind of sounds like tubules or tubes. And when you look down here, look at the glands, you see these huge tubular long tubes all throughout, and a relatively flat surface. That's defining for tubular adenomatous a polyp. Okay, so now we're moving to the next one. This is very high yield. This is villous. Do you remember at the very beginning of the video, I said, what are the features for malignancy? I said really large and increased size would mean they're more malignant. If they're sessile, which means when you look at the mucosa, they're firmly attached versus pedunculated. These are the sessile ones are more malignant. And then I said the last feature would be villous histology. And that is now where we've reached that. A villous polyp, you need to know this is high yield, is the most malignant. It has the highest malignancy potential. Highest malignancy potential. I keep using the word malignancy. Maybe I should say highest neoplastic potential because malignancy is different than benign, but both are cancerous. Okay, so the highest potential, let's say, to become neoplastic or become cancerous. This is the highest potential. Now, when you look at this, remember I described villous to you earlier, and I said if you were to look at the small intestine, you would see this kind of thing going on the surface, and these are called villi, right? And these villi are good for absorbing things, and that's that. You know, the duodenum is the primary place for absorption of nutrients and whatnot. So this is villous polyp. Now let's look at how this is. Up, down, up, down, up, down, up, down. And notice there's not a lot of open tubular spaces. They're kind of more closed off here. This is what's called a villous polyp, and this has extremely high malignancy potential for these polyps to become malignant. Therefore, if you see these, you need to definitely take these out and remove that. What's called a polypectomy. That's the name for cutting away of a polyp, usually by using this like little wire loop thing, and they put this is a wire attached to like a steel, like a rod there, and then they can wrap that wire around it and close it off, and then basically remove the polyp by ripping it off like that. Okay? So that's a villous histology there. And then the last one is tubulovillous. It's hard to kind of find a good picture of this, but you can see on this side, can you see that this is tubular more so? And then on this side, this is more villous. Right? Look at all the open spots here. Look at all the tubes on this side, the glands. And look over here. You can kind of see that what's going on right here. That going in and going out, that's villous. And this is a polyp that has it fairly separated between the two. But I want to let you know that you can see tubulovillous presenting kind of together. They're not going to be necessarily separated. One side is tubular and one side is villous. You can actually have a villous histology that has tubes, those glands within the villi, right? That's kind of all over within the villi, and that would also be tubulovillous. Okay, so that's just a mix between the two, and so it has features of both. All right, so now that we've gone over all of the primary types of colonic polyps, we need to get into looking at the adenoma carcinoma sequence. So let's say that we have a villous polyp, a villus polyp, and this villus polyp is now about to become cancerous. So remember that a villus polyp is also called a villus adenomatous polyp. It's called adenomatous because it can turn into an adenoma, right? It has the potential to become cancerous. So what is this adenoma carcinoma sequence? So this is basically a polyp that can turn into a polyp that can then turn cancerous. Let's just say that. That's a simple way to put it. So this adenoma polyp will eventually turn into carcinoma, and there's a sequence of factors that cause this to happen. So we have this villus adenoma, and to begin, a villus adenoma, an adenomatous polyp, if a patient were to have this, they probably had an increased APC. This is the APC gene. Now, this gene is important because whenever somebody has an increase in APC gene mutation, let's say that, APC gene alteration or increased APC gene, however you want to say it. Basically, the APC gene would be messed up in a certain area of the mucosa of the colon. Then when you have that, you increase the risk for sometime in your life for the formation of an adenoma from that polyp. Okay, from that polyp. Now I'm emphasizing that it's only increasing the risk. It's not actually causing the formation. Now what will end up happening, because of this increased APC gene mutation that's going to increase the risk for an adenoma to form from that polyp, then when the adenoma, say it would eventually form, it is being formed because of what's called a KRAS mutation. So now the actual formation of that adenoma. So this is actually causing the formation of the adenoma. So the actual production of the adenoma is from a KRAS mutation. And then last, this adenoma mutation then to progress into an actual full-blown carcinoma state or cancerous state is going to be because of increased P53, you could say cyclooxygenase mutation or alterations. Okay, and that's what's going to actually cause the carcinoma, the adenoma to then become like an actual cancer that is dangerous. Okay, so you need to know this sequence. So we went through all the different types of polyps, and I said that a villus adenomatous polyp has the highest chance to become an adenoma and then to eventually become cancerous. Well, what's the cycle of that? Well, you have this villus polyp. There's nothing wrong with it, but you know that they probably have an increased APC gene mutation at that site, which would increase the risk for that to eventually become an adenoma from that polyp. And eventually it happens, and then it causes an increased KRAS mutation, and this is what forms the adenoma. And then you have increased P53 and cyclooxygenase mutations that actually causes it to become a dangerous, a cancerous form, the carcinoma. I want to remind you, cyclooxygenase, specifically 2 is what we're talking about here. And so imagine if you're trying to stop this formation of the adenomatous polyp, if you're trying to stop it from becoming truly cancerous, what could you do? Well, you could inhibit cyclooxygenase 2. And what medicine does that? Remember that aspirin inhibits it. So a doctor will sometimes prophylactically give aspirin to these patients who have had a history, let's say, of villus adenomatous polyps, to try to stop this polyp from becoming cancerous. Okay, so that's what's called the adenoma carcinoma sequence. And so that's really important to know even after knowing the types of polyps and how they present. Okay, and the last thing I want to talk about besides this is just a really quick thing on left and right colon cancer. So left colon cancer and right colon cancer, which I've already written. So let's just think of the basic anatomy of the colon. So the colon just stands, that's another word for the large intestine, and we know that you have the cecum, the ascending, transverse, descending, sigmoid, and then into the rectum, right? So this is the ascending, the transverse, the descending, sigmoid, and then the rectum. And this is the cecum, or towards the very beginning of the large intestine. So now you could basically split the large intestine in half. So say you were looking at this patient head on. So here's the patient's eyes, right? And they're smiling. Okay, whatever. Say you were looking at this patient who was looking back at you. This would be the left side of the patient. This would be the right. So don't forget that, especially when you look at imaging. Even though you would think, oh, well, the left side's over here and the right side's over there. Well, yeah, that's when you're looking through your own eyes and looking out into, the world. But in reality, when you're looking at a patient, this is the left side and then this is the right side. Okay? So this is I've drawn a line right through this patient. Okay? And this is the left side of the patient. This is the right side. So you could hear a term said called left colon. And left colon, when you do have an eventual cancer that is on the left side of the colon, the cancer itself is going to be usually caused because of the APC, this adenoma carcinoma sequence, because of an APC mutation. It's going to be because of that. So usually if they say that there's a colon cancer, like a colorectal cancer, and they're telling you that it's in the descending part of the colon, or they're telling you it's on the sigmoid or the distal transverse, that's the left colon. So you need to be thinking what caused it is probably a polyp because of this adenoma carcinoma sequence. And then they can ask all sorts of questions about then they can ask all sorts of questions about how did this carcinoma form? And it may not be enough to just know APC. You may need to know the specific steps. Now on the right side, if you had let me finish the left side. Sorry, one other thing to say. For left colon cancers, they typically form what's called a napkin ring malignancy around the colon. So say this is your distal, say this is the descending colon. When a cancer were to form from the polyp, it forms what's called a napkin ring cancer state around it, and it squeezes this colon in. What that does is that doesn't allow stool to pass through the colon very well. The eventual that's going to exit out of the body. So you end up having a diagnosis. You could ask the patient, okay, what does your stool composition look like? Like, what does your stool look like after you go to the bathroom? And they could describe when they go to the bathroom, it's very, very thin and pencil-like. Okay, instead of being normal and like thick, it's like very thin, like a pencil. So pencil thin stools, that's kind of hinting towards a colorectal carcinoma from the left side, okay, because of this. And also then another feature would be constipation. Well, that's kind of common sense. Constipation, because this napkin ring formation here is squeezing down and constricting the colon, and it's already more narrow on the left side, so that's going to cause constipation. And then for the right-sided colon, so if you had a right-sided colorectal carcinoma, they could say, okay, the patient has a colorectal cancer or a mass in the cecum, or the ascending or the proximal transverse, whatever they decide to say. If it's on the right side, it's not usually caused from a polyp. Then this cancer could be caused from basically an alteration in the DNA mismatch repair. Do you remember when you have problems like when you're forming DNA and you're putting the bases and all that together to make the DNA and to match it up, the two sides of the DNA helix, that you can have errors, and then that error is fixed by one of the things that fixes it is a DNA mismatch repair protein or whatever, or gene. And this gene can be messed up, and this can cause something called hereditary non-polyposis colorectal carcinoma. So let's just look at what each letter means. Hereditary means, okay, it can be passed down. This is a genetic problem. Non-polyposis, okay, so this is not caused by polyps. So this cancer will just arrive by itself de novo. It doesn't arise from a polyp like this other side. The left side usually what happens is you have a polyp that has the potential to become malignant, and then it goes through that whole sequence. This side does not go through the adenoma carcinoma sequence. This side happens with this DNA mismatch repair gene problem. And then specifically from this, with this DNA mismatch repair gene, you have what's called a instability. Let me get the wording right for this. So you have what's called microsatellite, sorry about the misspelling, instability. And remember that microsatellites are just those repeating areas of non-coding DNA within your DNA chain, and they're present just throughout as non-coding segments all throughout the DNA chain. And every time that you have DNA replication take place, normally these are protected and formed normally, just like you would expect the rest of the chain to be. But if you had a lot of mutations in this, you can imagine that you would begin to have mutations all over and then eventually it would cause problems with DNA replication, and you can have a cancer on the more on the right side of the colon, and this is what's called hereditary non-polyposis colorectal carcinoma. It's a mouthful, but just know that this is the primary subtype within this problem of DNA mismatch repair gene causing microsatellite instability. So I know that's a lot of detail I kind of threw at the end there, but I wanted to make that clear because they could try to, it's important to know for our topic of colonic polyps that the left colon is primarily having cancers arise from neoplastic polyps. And what's the most common type? I just want to remind you again, it's the villus polyp type. And what are the other features? Well, if a polyp is sessile, remember that's firmly attached to the mucosal wall, that's more malignant. And if the polyp is more large, if it takes up more surface area, it has far more potential to become malignant. And that is the important details for colonic polyps. I'll see you in another video. Bye, guys.